Okay, so let's talk about cardiac rhythms. First, we're going to review what is normal. So, normal sinus rhythm can vary depending on age and athleticism. Um, Infants, 100 to 160 is the general rule, and that even varies depending on the age of the infant. So, brand new infants versus 9 to 12-month infants. See where I'm going at? Will vary depending on the child. Normal 60 to 100 for children over 10 and adults. Athletes, you might see 40 to 60 as their resting heart rate, and that's still within the range of normal as long as they're not having any other symptoms. A normal rhythm that you will hear has the S1 and S2. Remember, S1 is closure of your mitral valve and it makes the lub sound. S2 is the closure of the aortic and pulmonic valves, making the dub sound. Lub dub. Components of normal, I just put this on here for you. So you have your P wave. There must be a P wave with every QRS. That's a huge one to remember. The rate, like we said, 60 to 100. The P wave here is upright. And sometimes you might see where the P wave goes down. That could be depending on where the leads are placed, but it should be an upright P. Sinus tachycardia is the first one we will go over. So the rhythm is still a regular rhythm. What I mean by that is you still see a P wave for every QRS. So if you find this, these are your P's, QRS, and you can chart that out. Another thing is that if you were to take a little measuring tool, these QRSs would match out and the P waves would also march out, meaning that the spacing and the time between each P and QRS complex would be the same. The causes: exercise, of course, anxiety, too much caffeine, nicotine, fever, we've seen that, shock, again, congestive heart failure, hypotension, pain, kind of the pain response of the body. Hypoxemia can raise the heart rate, or even an anterior MI. Sinus bradycardia, so that is a rate less than 60. And like I said, for athletes and some folks, that might just be their normal where they just sit at 52. But if they are having symptoms, so they are really weak and fatigued, sweaty, pain, anything like that, and if this is going down into the 30s and there's obviously an issue, then we need to get that fixed right away. Other things: vagal maneuvers, glaucoma. Where I worked in IR, we would do carotid angios and we would do balloon angioplasties, that kind of thing. And it was interesting watching these folks because it would almost cause a vagal maneuver in them, and those heart rates would go from 70s to 20s in a matter of seconds. So very, very interesting. Have your atropine ready if you're doing that. Premature ventricular contraction, an ectopic beat is essentially what this is. It comes from the ventricles. So if you will notice, there is not a P wave here. So here you have, this would be a P, QRS, here's your T wave, P, QRS, T wave, extra beat, and then it takes it a second, here's your new P, QRS. So that's what I'm saying is watch, because this is probably a normal sinus rhythm, and then all of a sudden the ventricles decided to just fire again. Causes are hypoxia, hypotension, anemia, ischemic heart disease, electrolytes, so think potassium, if they're throwing out a lot of these. Supraventricular tachycardia. So these are the folks that feel like their heart is racing when it in fact is. The rate is 160 to 250. It's still a regular rhythm. So they still have, even though you can't really see it, there is still a P wave for every QRS. It's just kind of buried in the fact that it's a very quick rhythm. these people, we need to get them fixed right away. We do not see where it starts, but we can see when it stops if we treat it correctly. First, you will do the vagal maneuver. So these are the people that you tell to bear down like they're on the toilet. There have been uses with ice buckets and other things like that. But always make sure you've got them on the EKG, get the crash cart out, get the IVs in, and then if the vagal maneuvers don't work, then the docs will move forward with medications. Atrial flutter. So this is one that I've seen a lot of people get confused with ventricular tachycardia. Again, the biggest thing to note here is that you still have QRSs, okay? With ventricular tachycardia, the only thing that you have is a ventricular beat. You do not have any sort of P waves. And while A flutter, these are not necessarily considered P waves, they're considered F waves. You still get the general idea that here is, this F wave, FFF, and then eventually the QRSs will catch up, and then FFF, and then a QRS catches up. So your atrial rate is actually 250 to 400 atrial beats to 70 to 150 ventricular beats. Atrial fibrillation, it's similar to the A flutter where we have no P waves, we call them F waves. The atrial rate is 350 to 600. And if you think of fib versus flutter, fib means there's no rhyme or reason to it, where flutter, if you think of a butterfly, he's fluttering in a pattern and it has some consistency to it, whereas fibrillation is just kind of a crazy, chaotic wave, no rhyme or reason. So some people can be controlled AFib, where this is not new for them. They go in and out all the time, and they take their aspirin so that they don't develop clots and strokes and all that good stuff. The uncontrolled folks, that ventricular rate might be over 100 because the QRSs are still trying to find some semblance of normal and continue to march out. Pulseless electrical activity. This is, of course, it looks like a normal sinus rhythm, but there's no pulse associated with it. So if you're asked a question about pulseless electrical activity, you will most likely, if not always, be alerted by, this patient does not have a pulse, and that will be right up at the top of whatever question you're being asked regarding PEA. So blocks. Blocks are confusing, blocks are hard, and we try to understand them. And when we think we understand them, then we still get confused. So you're not alone. This is second degree AV block, Mobitz type 1 or Wenckebach, okay? So Wenckebach, longer stop. And what that means is you will see your P wave with a QRS complex, and then you'll see a P wave here, and notice this gets a little longer, and then here's your QRS, and then you have another P and a longer area, and then a QRS, and then another P, and then it's even a little bit longer, and then another QRS, and then here's a P and no QRS. And then it goes back to this, and if you were to measure this to that, it would be very close, and it will continue out in that progression, okay? Second degree AV block type 2. There's regular or irregular rhythm. The QRS is normal to wide, and the PR interval is constant. What that means is it does not get longer. The P's are marching out. So if you were to take your measuring tool and go from here to here, here to here, here to here, it is a consistent spacing. There is just not a QRS complex for every P wave. So the problem here is that the QRS is not responding to our every P wave. Third degree is a complete heart block, so there is no alignment with our P waves and our QRS waves. What this means is our P waves are charting out, so there's actually a P wave here, and then a P wave, P wave. See how that's all consistent? And then the QRS waves are even consistent, but they're not responding to one another. It looks like it might be responding, but it's not. This is going on its own without the P wave. Here's your VTAC. So it looks like a tombstone. That's a biggie. You don't see any semblance of trying to have a P wave because there are none. And this is simply a ventricular beat. So there is no PR interval, there is no P wave. Your rate will be above 100, but it's still a regular rhythm, meaning that it's not getting fast and then slow and then fast and then slow. It's generally stays like in the 170s, who knows what. This is a monomorphic VTAC that I'm showing you. I'll show you a polymorphic VTAC here in a minute. The main thing with ventricular tachycardia is if you have a patient and they're hanging out and they're not in VTAC, and then all of a sudden their rhythm switches to VTAC and you're like, well, that doesn't look normal, please go check them and see if they're number one, awake, alert, and have a pulse, because they may or may not be awake, alert, with a pulse. So that is a huge thing to identify. Ventricular fibrillation, this one is not VTAC. So again, thinking a flutter versus a fib, similar to thinking ventricular tachy to ventricular fib. Anytime you see fib, just know chaotic. There is no rhyme or reason to this rhythm, and it's always, I think it's worse. Especially VFib is worse because they will not have a pulse, they will be coding, and you need to take care of them right away. Torsades, I don't know why, but this one's my favorite. It kind of looks like sound waves to me, but the biggest thing to remember, if you see this rhythm pop up and it asks you, what do you think is the electrolyte that's causing this? Magnesium. Just, if you see torsades, think magnesium. Or if you see a question that says this rhythm is best treated with magnesium, think torsades. Just get that in your brain. It's worked really well for me. Just one of those things you just have to know. Asystole, flatline. Don't shock it. Don't be like Grey's Anatomy. Here's my references. I hope you enjoyed our little discussion on cardiac rhythms. I did not go into depth about how we treat each rhythm. I trust that you can look at that yourself. This was more just the down and dirty. I want you guys to have some reference. You can go back and look at these rhythms to know what you could be looking at, especially those blocks. So I hope this was helpful.